Hello dear students, welcome to this class on amenorrhea where we will be talking about both primary and secondary amenorrhea. What actually do you mean by amenorrhea? Amenorrhea literally means when there is absence of menstrual cycle. Absence of menses is literally termed as amenorrhea. So for how much duration the menses should be absent and what all we will talk over here. Okay. So absence of menses can be both physiological and can be pathological. It can be physiological as well as it can be pathological. So what are the causes of physiological amenorrhea? Physiological amenorrhea. There are 4 causes of physiological amenorrhea. Before puberty means before the menses have started, before menarche, patient will have amenorrhea. Number 2, after menopause. After menopause also patient will have absence of menses. And thirdly, during pregnancy as there is progesterone in the body and there is no ovulation, so patient will have amenorrhea. And number 4 will be during lactation. During the period of lactation there will be lactational amenorrhea, which is governed by the Bellagio criteria. Bellagio criteria. I hope you know the 3 criteria. So this is what is physiological amenorrhea. Pathological amenorrhea can again be divided into either primary amenorrhea or secondary amenorrhea. Primary amenorrhea means patient को कभी menses start ही नहीं हुआ है. She has never menstruated. Means delay in your menarche. And secondary amenorrhea is patient was previously menstruating properly but now she is having amenorrhea. Okay, so first let us come to the development of the female genital organ. Just a recapitulation because I have already talked in my previous lectures. You can go into the this channel and you can see it. For normal development of the gonads or ovaries, absence of Y chromosome or SRY gene ka absence is very much required, and 2 X chromosomes are required to have a good gonad. If there is 1 X chromosome, that is XO, which occurs in Turner syndrome, there you will have streak gonads. So both X's are required for the ovaries to form properly. So ovary then secretes estrogen, which is required for normal development of secondary sexual characters. Secondary sexual characters are in the form of your pubic hair, okay, and your axillary hair, okay. These actually are brought about by dihydrotestosterone in the body. But dihydrotestosterone is formed from testosterone, and testosterone only is being aromatized into estrogen. So if estrogen is present, it is an indirect evidence that testosterone and dihydrotestosterone are also present. And testosterone is converted to estrogen by aromatase enzyme, which helps in aroma. Aroma is being referred to females. Okay, so male to female hormone is aromatase, whereas 5-alpha reductase is the hormone which helps in changing the testosterone to dihydrotestosterone. So also the Mullerian inhibiting hormone or Mullerian inhibiting substance is not there in the female body because testes produce Mullerian inhibiting substance. So when Mullerian inhibiting substance is not there, then Mullerian glands keep on developing, and Mullerian ducts will form your uterus, your fallopian tubes, cervix, and upper 2/3 of the vagina. Whereas lower 1/3 of the vagina is formed by the urogenital sinus or sinovaginal bulb, okay, and then it will fuse with the upper vagina, and then the transverse vaginal septum will dissolve. So this is what is the development. So the first problem in primary amenorrhea. What actually is primary amenorrhea? It is a condition where the female has not attained menarche. Okay, very important definition of primary amenorrhea is The menarche is not yet obtained. Menarche is not yet obtained at the age of 13 years in the absence of secondary sexual characters. If secondary sexual characters are also not formed, then by 13 years only we will make a diagnosis. But if the patient is having secondary sexual characters, that is axillary hair, pubic hair and breast are also formed, then you wait for 2 more years. So till 15 years you wait, and by 15 years also she has not had the menses in the presence of secondary sexual characters, then you say patient has primary amenorrhea. Okay, similarly, how do you define secondary amenorrhea? Secondary amenorrhea is defined as absence of menstruation for 6 months, absence of menstruation for 6 months or 3 consecutive cycles. 3 consecutive cycles. Okay, so this is the latest definition. So always remember, this is the definition. So absence of menses for 6 months or 3 consecutive cycles. Okay, in a previously menstruating female. Okay, so this is the definition of secondary amenorrhea. So let us come to primary amenorrhea in details. Primary amenorrhea. So in primary amenorrhea also you can divide it into 2 types. One is cryptomenorrhea. What do you mean by cryptomenorrhea? Cryptomenorrhea means, crypto means hidden. So the menses तो हो रहे हैं but वो hidden हो रहा है. Hidden का क्या मतलब है? Occurrence of menstrual symptoms without external bleeding. So means patient's endometrium is bleeding every time, but the blood is not coming out because there is obstruction in the external genitalia. Menstrual blood fails to come out from the genital tract due to obstruction in the outflow passage. Okay, so there is obstruction in the outflow passage. Now, cryptomenorrhea can be again divided into either congenital or acquired form of cryptomenorrhea. Congenital form of cryptomenorrhea can be in the form of, most common cause will be imperforate hymen. Most common cause is imperforate hymen. Okay, followed by the second most common cause will be transverse vaginal septum. Now understand what happens if the hymen is imperforate. Hymen कहाँ पे होता है? This is the uterus, this is the cervix, and this is the vagina which has started. So the vagina comes and opens in the vulva. Okay, so the vaginal opening is governed by the introitus, has the a membrane type of covering which is called the hymen. So this is the hymen in the vaginal orifice, or the introitus. Now if this hymen is imperforate, then all the blood will get collected first in the vagina. Then it will again get collected in the uterus, endometrial cavity में हो जाएगा. उसके बाद भी फिर आपने सर्जरी नहीं किया, then आपके ट्यूब्स में भर जाएंगे, and then it will keep collecting in the peritoneum. Peritoneal cavity. So based on that, patient will be having hematometra. Metra means vagina. Metropathy or something called vagina. Hematometra. After that, patient will have collection in the uterus. Okay. Hematocolpos is in the vagina. Then hematometra is in the endometrial cavity. And then it comes to the tubes called hematosalpinx. Okay, so these are the blood collections which occur. These can be visualized in ultrasound as well as in MRI. It can be visualized. Ultrasound and MRI are the modalities. Investigation of choice will always be MRI, because it will help us in determining the level of the block and what type of surgeries to be done. So imperforate hymen may only there is a membranous covering. So the treatment of imperforate hymen is to just give a cruciate incision in the hymen. Cruciate incision का क्या मतलब है? A cross sign or plus sign incision, just you have to incise the hymen this way, and then the hymen will start bleeding. Okay, all the blood from the collected blood will start coming out. What will these patients present with? The clinical features with which the patients will present is, patient will have amenorrhea, no doubt. There will be primary amenorrhea. Patient's secondary sexual characters will be normal because the ovaries are functioning properly, and so estrogen and testosterone, everything is normal. So secondary sexual characters, breast, axillary hair, pubic hair will all be normal. But patient will have cyclical abdominal pain every month. Cyclical abdominal pain every month. Pain every month. Why? Because every month जब इनके मेंसेस का टाइम आता है, मेंसेस तो बाहर आता नहीं है, तो पेशेंट विल हैव क्रैम्पिंग पेन एट दैट टाइम. ओके, तो साइकिलिकली सर्टेन पार्ट ऑफ द मंथ में ही हमेशा पेन आता है. दिस इज वेरी वेरी स्पेसिफिक फॉर क्रिप्टोमेनोरिया. Apart from that, patient can have distension in the abdomen. Distension in the abdomen. Because abdominal distension can be there if the blood collection is very high. बहुत सालों से blood collections बहुत high हो जाता है. Every monthly there is bleeding, and so this blood collection can lead to abdominal distension, and pain and tenderness can also be there. Okay, on examination and genital examination, remember you never do pervaginal examination in such patients. Per speculum and pervaginal examinations are never done in unmarried female. So what you can do is you do a local examination of the genitalia, and you will find a bluish bulge present. Bluish bulge present around the hymen or in the vagina. The bluish bulge says that there is blood collection inside, and since it is a membrane, hymen is just a membrane, ये ऐसे bulge करेगा because it is a soft membrane, so it will keep on bulging. When there is bulging or bluish bulge present, then you know कि this is imperforate hymen. Whereas if all the symptoms, signs and everything is same as imperforate hymen, but bluish bulge is absent, then it means that it is a thick membrane. It is not just a thin membrane, it is a thick membrane, and thick membrane is present in transverse vaginal septum. Transverse vaginal septum mein the membrane is thick. So in this case, the vaginal septum is in the vagina. In the vagina, it can be either lower vaginal septum, or it can be mid vaginal septum, or it can be in the upper transverse vaginal septum. So all the vaginal septums are very thick, and so bulge and bluish bulge will be absent. So bluish bulging in local examination helps us in differentiating between imperforate hymen and transverse vaginal septum. So treatment of imperforate hymen, I have already told, is very easy. Cruciate incision. Transverse vaginal septum का treatment क्या है? You have to go for cutting the transverse vaginal septum. You have to cut it, followed by anastomosis of the vaginal wall. Anastomosis of vaginal wall. Okay, you have to anastomose the vaginal walls. Like this is the vagina, this is the transverse vaginal septum. You have to cut it, and then you have to anastomose the upper and the lower part of the vagina. So upper and lower vagina has to be anastomosed properly. This has a poor prognosis. Transverse vaginal septum has a poor prognosis क्योंकि वो बार बार जुड़ जाता है. But your imperforate hymen has a very good prognosis, because just a cruciate incision will help in relieving all the symptoms, and generally it does not reanastomose. Okay, so this is cryptomenorrhea. So cyclical abdominal pain is present, and by looking and examination you can do. Since PV and PS are not done, you can do a per-rectal examination if you try to just palpate how much is the distension present, how much of bleeding has been there, whether the uterus is distended or not. You can do in per-rectal examination, but never do per-vaginal examination. Okay, so this is cryptomenorrhea. Now coming to major causes of primary amenorrhea. Before this, let us see the physiology, how menstruation generally occurs. Okay, So this is the central nervous system. Central nervous system में you have the hypothalamus. Hypothalamus secretes GnRH, gonadotrophin releasing hormone, which helps in stimulating the anterior pituitary. Anterior pituitary secretes FSH and LH. FSH and LH, follicle stimulating hormone and luteinizing hormone, are produced. They come to the ovary and stimulate the follicles, get secreted, the recruited, and estradiol is secreted, and LH helps in ovulation, formation of corpus luteum, and thereby progesterone is formed. And estrogen, progesterone both act on the endometrium to form its milieu, and then menstruation occurs. So this is the entire thing. Now based on this, they can be divided into: uterus is compartment 1, ovaries are always considered as compartment 2, compartment 3 is your anterior pituitary, so we go from below upwards, and compartment 4 is always your hypothalamus. So whatever will be the level of the defect, we say ki there is defect in compartment 1, compartment 2, compartment 3 or compartment 4. Now coming to a tabulation compartment wise, what can be the major defects? Compartment 1 में there will be outflow tract disorders of outflow tract, like your all the Mullerian abnormalities, whereby Mullerian duct will not be formed properly, and so uterus and fallopian tubes will not be formed. Okay, this is the Mullerian abnormality. Most common cause is MRKH is Mayer-Rokitansky-Kuster-Hauser syndrome, where there is complete absence of bilateral Mullerian ducts. When the Mullerian ducts are not there, then what all things are not formed? Uterus is not formed, then the bilateral fallopian tubes are not formed, cervix is not there, and upper 2/3 of vagina is not there. But ovaries are normal because ovaries are not formed from Mullerian duct, they are formed from genital ridge. So MRKH patients will have normal ovary है तो normal estrogen secrete हो रहा है, normal androgen secrete हो रहा है, तो secondary sexual characters इनका normal है, इनका breast, axillary, pubic hair सब कुछ normal है, but then they will not have any menses because they do not have these structures. But lower 1/3 of vagina will be present because it is formed from urogenital sinus or sinovaginal bulb. से lower 1/3 of vagina. So on examination they will have a blind vagina. उनका vaginal opening blind हो जाएगा, lower 1/3 ही है, and then they will have only ovaries. The rest of the structures won't be there. So MRKH, very important, is the second most common cause of primary amenorrhea. Remember, the second most common cause of primary amenorrhea is MRKH, and so this is compartment 1 disorder. The second disorder which comes in compartment 1 is your testicular feminization syndrome or androgen insensitivity syndrome, where the individual is XY. The individual is actually a male, genotypically male, but the problem is there is 5-alpha reductase deficiency, or the testosterone receptors are not present, testosterone receptors are absent, and dihydrotestosterone receptors are absent. So what happens, टेस्टोस्टेरॉन तो है बॉडी में, बट टेस्टोस्टेरॉन 5-alpha reductase नहीं है, तो टेस्टोस्टेरॉन इज नॉट गेटिंग कन्वर्टेड टू डाईहाइड्रोटेस्टोस्टेरॉन, and dihydrotestosterone is responsible for the external genitalia of male. सारे external characteristics, external genitalia is governed by dihydrotestosterone, whereas internal male genitalia is formed by testosterone. So what happens is the internal organs will be male, that is the testis will be formed, and then bilateral vas deferens will be formed. बट देर विल नॉट बी पेनिस फॉर्मेशन, पेनिस नहीं होगा क्योंकि एक्सटर्नल कैरेक्टरिस्टिक मेल का नहीं होगा. ऑल्सो डाईहाइड्रोटेस्टोस्टेरोन इज रिस्पॉन्सिबल डाईहाइड्रोटेस्टोस्टेरोन से होगा, axillary hair, pubic hair. So all these axillary and pubic hair will be absent. So patient will be a male genotypically, but बाहर से उसका कोई भी जो फीचर है वो मेल की तरह नहीं होगा. So बाहर से he will look like a female, बाहर से he will look like a female. Also टेस्टोस्टेरोन ज़्यादा होने के कारण क्या हो जाएगा, testosterone will get converted to estrogen by the effect of aromatase enzyme. So estrogen level will increase in the body, and so breast development will occur. So see, finally the testicular feminization syndrome या androgen insensitivity syndrome वाले जो individuals है, they are males, but since their dihydrotestosterone is not able to act, बाहर से वो फीमेल की तरह दिखेंगे, बाहर से वो बिल्कुल फीमेल की तरह एक्सटर्नल अपीयरेंस होगा. ऑल्सो दे विल हैव ब्रेस्ट बिकॉज द टेस्टोस्टेरोन गॉट कन्वर्टेड इनटू ईस्ट्रोजन एंड ब्रेस्ट डेवलपमेंट हो गया. सो दे विल लुक लाइक फीमेल, दे विल बी टॉल फीमेल्स, वेरी ब्यूटिफुल फीमेल्स टू लुक फ्रॉम आउटसाइड, but when you do karyotyping they are actually XY, they are males. Okay, so this is testicular feminization syndrome or androgen insensitivity syndrome. This is the third most common cause of primary amenorrhea. Okay, so second most common cause we have found is your Mullerian MRKH, and third most common cause is testicular feminization syndrome or androgen insensitivity syndrome. Both are external genitalia, that is external compartment 1 defect. Coming to compartment 2 defects. Compartment 2 defects are disorders at the level of ovary. So these disorders, what can it be? It can be gonadal dysgenesis, most common. मीन्स ओवरीज में प्रॉब्लम है, ओवरीज स्ट्रीक ओवरीज है, ओवरी सही से बना नहीं है. मोस्ट कॉमन कॉज इज योर टर्नर्स सिंड्रोम में इट इज द क्रोमोसोम इज XO, and remember this is the most common cause, that is the first most common cause of primary amenorrhea. So most common cause of primary amenorrhea is Turner syndrome, followed by second most common cause is MRKH, and third most common cause is testicular feminization syndrome or AIS. Okay, apart from that Turner syndrome, you can have Swyer syndrome, Savage syndrome. These are all gonadal dysgenesis, and I have already talked about all these syndromes in details in my previous lectures, which I have clubbed it in the gynae theory section. You go to congenital malformations and sexuality classes, where you will find in much details. I have also tabulated these, what are the differences between these. Then coming to section 3, that is the compartment 3 disorders, that is anterior pituitary में there can be prolactinomas, all the tumors in the anterior pituitary, there can be prolactinomas, there can be hypopituitary states, like hypopituitary states can be pituitary hypoplasia or hyperplasia. Then there can be other things like neoplasias. Okay, all these can be categorized into category 3 or the compartment 3. Compartment 4 is at the top, that is hypothalamus disorders. Most common example is your Kallmann syndrome is basically problem in the hypothalamus, whereby there is midline defect in the body. Means all the structures originating from the midline, like your nose, your nasal plate, then your hypothalamus of the brain, these all structures are not formed properly. So as a result of which patient will also have anosmia, patient will have primary amenorrhea, साथ में patient को smell नहीं आता है, okay, anosmia. So if somebody has anosmia along with primary amenorrhea, then you diagnose the patient as Kallmann syndrome. Treatment of all these are dependent upon identifying the cause and making the treatment. Okay. Coming to your secondary amenorrhea. Okay. Now the causes, everything. What you need to study here is in detail. You have to study about Turner's syndrome. I'm giving a gist what all have to be studied, because these I have already recorded lecture separately, so I will not go into detail. Turner's syndrome, Kallmann syndrome has to be studied in detail. Then you have your testicular feminization syndrome or androgen insensitivity syndrome to be studied in detail. And then your MRKH. How do you differentiate between them? You have very frequent questions from all these, and you need to know them properly, how you differentiate them clinically, as well as how you differentiate them on investigation basis. Coming to secondary amenorrhea. Secondary amenorrhea can be because of various reasons. Again, you can divide it into compartment 1, compartment 2, compartment 3 or compartment 4. The most common cause of secondary amenorrhea is pregnancy, of course, okay, followed by lactation. Pregnancy followed by lactation are the most common cause of secondary amenorrhea. But most common pathological cause of secondary amenorrhea, those were physiological. Pathological cause of secondary amenorrhea will be PCOS. PCOS is the most common cause of pathological secondary amenorrhea, followed by your premature ovarian failure and Asherman's syndrome and premature ovarian failure. Now PCOS is a separate lecture already taken. Go and just view it properly. So PCOS followed by Asherman's. What is Asherman's syndrome? Asherman's syndrome is when there is the endometrium has become non-functional. The endometrium has become non-functional because of genital tuberculosis. Most common cause is either genital tuberculosis or there is vigorous DNC done to the patient, dilatation and curettage. In such cases, the endometrium has become raw, and then the anterior, posterior or the lateral endometriums, they tend to get fused to each other. Okay, they tend to get fused. Once they become fused and there is adhesion formed in the endometrial cavity, the bleeding never occurs because the endometrium, functionality of the endometrium is disturbed and endometrium is destroyed. So this is called Asherman's syndrome. Asherman's syndrome is a very difficult condition, and most of the patients never get treated from Asherman's syndrome. The only treatment of Asherman's syndrome is hysteroscopic adhesiolysis. Hysteroscopic adhesiolysis of all the adhesions. Adhesiolysis. So what happens is, hysteroscopically go inside and under vision try to cut all these adhesion bands. If you cut them, then patient might regain, and after that you have to put the patient on estrogen and progesterone. Estrogen will help in proliferation of the endometrium properly. Progesterone will decidualize the endometrium, and then once you withdraw ENP, then patient might have bleeding. So this is how we treat Asherman's syndrome. Asherman's syndrome has been discussed in my genital tuberculosis lecture. Next, coming to your premature ovarian failure. Premature ovarian failure, POF, and or nowadays the newer terminology is POI, premature ovarian insufficiency, is when patient's ovaries become aged and the follicular reserve is destroyed at less than 40 years. अगर 40 years से पहले ही पेशेंट को मेनोपॉज हो जाए because of decreased ovarian reserve or DOR, decreased ovarian reserve, then patient is said to go into premature ovarian failure. How do you diagnose कि ovarian reserve कम हो गया है? By doing a serum FSH, follicle stimulating hormone, for these patients. Once the follicles are depleted, follicle है ही नहीं body में, तो ऊपर से क्या करेगा, anterior pituitary will be secreting more and more follicle stimulating hormone FSH, because body will think कि FSH को ज़्यादा बढ़ाना है, because the negative feedback of estrogen will be reduced. So since estrogen is reduced, your serum FSH keeps on increasing. So serum FSH value more than 40 international units at an age of less than 40 years, diagnosis of POF या POI. Okay, so FSH level more than 40 at age less than 40 years, diagnosis your POI. So once you have diagnosed कि patient को secondary amenorrhea है, then how do you generally go about? What is the management protocol? Management protocol is to give a progesterone challenge test. Progesterone challenge test. What do you mean by progesterone challenge test? Whenever patient is having secondary amenorrhea, first you do a urinary pregnancy test for this patient, क्योंकि pregnancy is the most common cause of secondary amenorrhea. Then also take history of lactation, whether patient is lactating the baby or not. If these are absent, then always get a thyroid profile done for the patient, because hypothyroidism is also one of the causes of secondary amenorrhea. And उसके बाद आप prolactin level भी कराएंगे patient का, because prolactinomas are also causes of secondary amenorrhea. Once you have ruled out all these things, कि there is no hypo or hyperthyroidism, there is no prolactinoma, and lactation is also not there, pregnancy is not there, then you give progesterone challenge test to the patient. क्योंकि sometimes जैसे PCOS वाले patients में there is persistently high estrogen and there is no ovulation, so progesterone तो body में है नहीं. So what we can do is we can give tablet medroxyprogesterone acetate, medroxyprogesterone acetate 10 milligram twice daily, 10 milligram BD you can give for 5 days. 5 days you can give the progesterone. So what happens is, when you give progesterone to the patient, progesterone has negative impact upon estrogen. So estrogen level को वो अपने आप कम करा देगा, and progesterone का concentration blood में बढ़ जाएगा, because you are giving progesterone. So once after 5 days when you withdraw the progesterone, a progesterone level भी कम हो जाएगा and your estrogen is already low, so this will lead to breakthrough bleeding. So patient will have menstruation. Okay, breakthrough bleeding, or which is also called as withdrawal bleeding. Withdrawal bleeding. This is called withdrawal bleeding, because you have externally administered progesterone. So this is progesterone challenge test. So progesterone challenge test say after 5 days when you stop, in the next 7 days after stopping, patient will start having menses. So अगर menses आ जाते हैं, then you diagnose कि basically it was progesterone deficiency in the body, estrogen was there, so that is why patient was having amenorrhea, secondary amenorrhea. So classical example is your PCOS. But if patient is not having menses even after progesterone challenge test, तो इसका मतलब है कि बॉडी में ईस्ट्रोजन भी शायद नहीं था, बिकॉज अगर ईस्ट्रोजन होता तो एंडोमेट्रियम ऑलरेडी फ्लफी होता एंड प्रोजेस्ट्रॉन उसको डेसिडुअलाइज कराता, लेकिन ईस्ट्रोजन ही नहीं है तो एंडोमेट्रियम नहीं बनेगा, तो डेसिडुअलाइजेशन भी नहीं होगा. सो इन दिस केस वी गिव बोथ ईस्ट्रोजन एंड प्रोजेस्ट्रॉन चैलेंज टेस्ट. We give both estrogen progesterone in the form of oral contraceptive pills. We give oral contraceptive pills. So oral contraceptive pills will have phases whereby first half में आपके estrogen बढ़ेगा, second half में your progesterone बढ़ेगा, and then you will have withdrawal and then patient will bleed. So if those patients who have not bled with progesterone challenge test, if we give E plus P challenge test and patient has bleeding, it means patient's body had deficiency of both estrogen and progesterone. Classical examples क्या क्या हो सकता है? All the compartment 3 and compartment 4 disorders, that is disorders in hypothalamus, disorders in the pituitary, or compartment 2 disorders whereby there is ovarian reserve has gone down, that is your either premature ovarian insufficiency or Turner's syndrome whereby there are streak gonads, or your Savage syndrome and Swyer syndrome. These all things also read from my previous lectures. Okay, so these compartment 2, 3 and 4 defects will have bleeding with estrogen and progesterone. So treatment of these patients will be, you have to give long time continuous to the patient so that their estrogen and progesterone level becomes normal. But if patient is not having bleeding even with E plus P, then the defect is in compartment 1, that is outflow tract obstruction. Like patient can have Asherman syndrome जहाँ पे endometrium बना ही नहीं है. Okay, then patient can have your cryptomenoria. All the type of cryptomenoria can be there, or there can be Amenorrhoea syndrome where the uterus and cervix are not formed only. Okay, so compartment 1 defect can be differentiated from compartment 2, 3 and 4. Now, when there is compartment 2, 3 and 4 defect, how to differentiate between them? So, first you try to do the FSH level for the patient, FSH follicle stimulating hormone level for the patient. If it is very high, it means कि हमारा defect ovary के level पे है. That is why your pituitary is secreting a lot of FSH. If FSH is very high, then it means that the defect is in the level of ovary. So it is premature ovarian insufficiency or Turner syndrome, Savage and Swyers. For this you have to do a karyotyping. For the patient, karyotyping has to be done. So it will differentiate कि आपका कौन सा syndrome है. But level is in the ovary, that is it is compartment 2 defect is known when FSH level is high. But when FSH level is low in the body, it means anterior pituitary is not able to secrete. So the compartment 3 or compartment 4 दोनों का ही defect हो सकता है. So when FSH level is low, next what you do is you go for GnRH levels in the body. GnRH level देखोगे. अगर FSH level low है and GnRH level is high, it means defect is in compartment 3. That is why compartment 4 or hypothalamus is secreting more and more GnRH. But if GnRH level is also low and FSH level is low, तो मतलब main problem सबसे ऊपर है hypothalamus में, compartment 4 में. So this is how you differentiate कि कौन से compartment में क्या defect है, and mostly इसमें patient को anosmia भी रहेगा because this is a midline structure defect and patient will have anosmia also because the nasal plate will not be formed. So this is how we keep on diagnosing and treating the patients of primary and secondary amenorrhea. This is just a gist. Along with this class, also see the congenital anomaly classes. You have 2 lectures on congenital anomalies, congenital malformations. I have recorded them and it is there in the channel. So also look for that because you also very frequently get questions on differentiating between MRKH, that is the Mullerians, and your androgen insensitivity syndrome or testicular feminization syndrome, and your Turner syndrome. So very, very important. So I hope you have understood the class. Any doubt, anytime you can call me up or ring me up. I will take subsequent classes also where I will try to clarify your doubts if you have any in this chapter. Thank you so much.